This lecture presentation follows your PowerPoint on hospitalized child and nursing considerations. We will look at reactions to illness of the hospitalized pediatric patient and their family unit, and nursing care that you would anticipate needing to be safe with. So we'll be looking at that. And in your textbook, information regarding the hospitalized child is actually on in chapter 40, page 1025. So there's some things that will be very helpful to you in that chapter that you'll want to look at. So without further ado, we're going to look at the hospitalized child. So you must first examine what your perceptions are. You know, do some inward reflection on yourself. You know, what is your view and understanding of children and families? And the family unit can be very different and totally different from what your culture and what your family situation was. So you need to be careful that you don't approach a family situation in that this is what I would do and I would expect them to do it, because that may never be the situation that you'll encounter. So we need to think of the expectations that we have. Are they realistic for that family? Have a good sound knowledge base, you know, using history and assessments to know where they're coming from, what's their frame of reference, and the family needs to feel that the child's important to you. For them to trust what you're asking them to do or change behaviors, you know, they need to feel that trust. Some of the nursing diagnoses that we'll see involved with the hospitalized child, of course, is the altered family process. You know, what are their coping skills? What's their insurance? You know, what's their work schedule? Can they miss any days to be, you know, with their child in the hospital or not? Do they have transportation to get to the clinic? So these are all things that we need to think about that in their regards to how they're coping. And so our goal would be that the family will exhibit use of appropriate coping mechanisms and stress levels are reduced. So the outcome criteria, I'd like for you to think about, how would you know in a family that you're taking care of, or extended family, regardless of the setting, what would be some measurable outcomes that you might see that would indicate stress had been reduced? So you need to think about those global, the goal is global and then the outcome is very measurable. And sometimes NCLEX test questions are centered on that. You know, what are you going to measure? What's your yardstick for measuring stress level reduction? So how do you define family, types of family, and who are the members that are going to be affected by this child's illness? And then how do you interact with them? Of course, remember the siblings. What is the effect of hospitalization on the family unit, and how do the stressors of hospitalization become observable to the nurse? What would you be assessing for every time that you are interacting with family? How are you going to determine that stress has been reduced? So with your study partner or your assigned group, I'd like for you to make a list of your assessments or interpretations of a picture that I'll show you in class on the first day. So you will post that on the discussion group for Nursing 213. And then our next slide, here are some of the components or some of the behaviors that we might see. And this was actually developed by a particular scientist who was examining changes in child's behaviors, particularly the toddler. And so we see this still referenced in textbooks. you know, everyone experiences at some time in their life separation anxiety. But when we think about a prolonged hospitalization, you know, what are steps that we might see change over time? Well, the first phase that we encounter is typically the protest phase. And some behaviors that you might see is the child, you know, fighting back. They're crying, they're screaming, they may cling to the parent, they're trying to push you away, and that's normal. We would expect to see that in that toddler. Now, if they are within the confinement of a hospital setting for a period of time and we do not use appropriate interventions, then what we see is this toddler lapsing into what's referred to as the despair phase. And some of the behaviors that indicate they're in this phase, their crying and pushing away has stopped, and they look sad. They have evidence of depression. So they look in despair. They're not understanding why all this is happening to them. They have no timeline understanding, and so they're just very depressed and sad and overwhelmed by it. Then the third phase, again, if appropriate interventions are not taken, we can see that the toddler or even preschooler would be in what's called the detachment phase. So what assessments made by the nurse would reflect the child being in this particular phase? They've resigned to the situation. They don't kick, they don't fight, they're not really affected in any way if the parent comes or goes. They'll go to anyone, and they kind of emotionally detached or pulled away from the situation. So we do not want, you know, despair and detachment to occur. So one of the things we look at is what are the stressors of hospitalization and what can the nurse do to make that different. So of course we examine the literature, evidence-based practice. Robertson and Bowlby are the two researchers that developed these stages. And so you may see these in your textbook as well, and you need to be sure and identify the 3 stages and know some behaviors that indicate that the child's in that particular stage. On page 1027, I would add, instead of those that are listed there, there is a table that you can look at that has that information in more detail. So disregard this particular reading, and this was for the 3rd edition. And so look at that in your 4th edition book if you would. Stages of separation anxiety. As I said, everybody experiences some separation anxiety. Even adults do. Say, like you come into your first class, you know, of nursing, there was some anxiety that you had in doing that. So here's this protest, despair, and detachment, and again, some additional symptoms that you might see. With your student partner or your group, there's 10 things that the nurse could implement to decrease altered family coping related to the stressors of hospitalization. And there will be a line item for you to post to in discussion board. So you would make that entry, and then you need to read everyone else's entries. This table gives some information on stressors of hospitalizations for children at various developmental stages. So here we can see, for example, the infant who is experiencing separation anxiety. Their sleep-wake cycle may be, you know, interrupted. They may be more irritable. And then, of course, the interventions, we want to encourage a parent or a caregiver to stay with the child at all times. And then know the child's routines and follow those as best as you can. A quiet environment. We never want the child to be exposed to any more than they can handle. So words, talking over the child about a procedure, those things, we would not want to do at any age level. The toddler, has a sense of loss of control. So they're going to cry if the parents leave their bedside, and they wonder why the parent's not coming to their rescue. And that is why sometimes when you're doing a procedure, you have to make a decision. The parent being there is making the child more resisted, because they're wanting the parent to stop this nonsense. So we have to make some decisions, but most of the time we want the parents to be there and to participate. Now, another important thing is you want to always allow choices, because they have this sense of loss of control, but they have to be choices you can live with. So you don't ask, do you want to take your medicine? Because, no, I don't want to take it, and then you can't live with that response. But what you might do, you go in with the expectation that, yes, you're going to take the medicine, that's your expectation, but you give them a choice. Do you want a drink of this or a drink of that? You want it in this cup or that cup? Do you want a sticker? So you give them a choice you can live with. When we move into the preschooler, again, you see separation anxiety again, and fear of abandonment, loss of self-control, bodily injury, and mutilation. So an example of this a lot of times is that you do an injection and they fear their whole body is going to leak out of that hole that's made from the shot. So often they'll want that Band-Aid on it as, quickly put a Band-Aid on it. The preschoolers have emerging fears. They may not have had fears ever before of anything, but this typical age group have, emerging fears, and being in a strange environment can only accentuate that occurrence. So again, encourage the parent to be there, allowing choices when possible, explaining procedures just as you're doing the procedure, not ahead of time. And they do not understand time frames. So if you're going to say your mom's going to come back in 30 minutes, they don't understand what that means. So you have to express that 30 minutes in an increment they understand. So it might be knowing they watch a particular cartoon and how long that lasts, say Dora the Explorer. Mom will be back when Dora Explorer is over. So, it gives them a frame of reference. The school-age child, again, has that loss of control, loss of privacy and control over bodily parts, fear of death, emerges during the school-age time. So we, again, want the parent involved, allow them to make choices. We're building upon those past interventions, explain procedures with anatomically correct diagrams or dolls, and explain what they can do to help the situation. So you're giving them a role of what they might do. The adolescent, the loss of privacy is very important to them. So sometimes, and they'll vacillate when we look at behaviors. One minute you walk into the room and they're like verging on adulthood and they want to make all the decisions, and then the next time you walk into the room, they've regressed to, a school-age period, and they want their parent there, and they can't do anything, independent of their parent. So we want to recognize, too, that their peers are very important, and that we, have liberal visitation if if medically is feasible to for them to be exposed to their friends. So with the infant, again, to summarize, it's trust versus mistrust, and they need that consistent, loving caregiver, and we need to follow their routines as much as possible. Then the toddler, the out of control, temper tantrums, daily routines and rituals are important. They're in autonomy versus shame and doubt. We often see regression of behavior when they're sick. They'll often say no when they really mean yes. So parents will often be very embarrassed about how the toddler is acting if they're showing these types of behaviors. And we need to support and help the family recognize that we would expect this and this is okay, and to reassure them on their parenting. Preschoolers, they're in preoperational thought. They're very egocentric. It's only their viewpoint. They can't see the viewpoint of others. And magical thinking, those fears emerging, and again, give choices that you can live with, as an intervention. The school-age child is striving for industry, and they like to make, do, and produce. And so we can tap into where they're at developmentally and have them make something for somebody else on the unit, to make something with their medicine cups. So they like to collect and they like to make and do. So that would be helpful for them. The adolescent, the loss of control and the need for privacy, again, to reassure them and provide, an environment that can enhance their independence, but yet include the family. So, we have to assess where they're at in that point in time. Common fears among children are bodily injury and pain, so we need some reassurance and follow-up, even positive statements of, okay, it's feeling better now, isn't it? I'm just pushing on your leg to put the Band-Aid on, and that's all the touch and all the hurt that you'll have right now. The effects of hospitalization can be seen before the admission, during, and even after when they're at home. Their concept of illness is more important than their intellectual maturity in predicting about how stressed they might be from that hospitalization. Then you also have to just consider, we have all these theories, we know where they should be developmentally, but then they're their own person. So are they typically a difficult temperament child? Does there seem to be a little bit lack of fit between the child and parent? They're not quite getting along. What is their age? If male or female, their intelligence, their intellectual ability to understand, and if they've had multiple continuing stressors, say if every week they have to go in for blood testing and then maybe a bone marrow aspiration, if that's happening routinely, that can be very much of a problem for their stress. And then what are the cultural differences? Are males considered to be more stoic? What are things that the father might be saying to the young boy, when he gets a shot? So those are all things to consider. We're seeing some changes in our pediatric population with more serious and complex problems. We're saving more babies, but often there's some fragile periods of time when they're more susceptible to situations such as how a fragile newborn might react to RSV versus, an adolescent. Then injuries, disabilities, and often we're seeing children that maybe had a longevity, of 20 years ago of only making it to adolescence, and now they're living into adulthood, such as we see with cystic fibrosis. And then the nuclear family is the minority of our families. So there's fewer traditional families. So again, that may be your frame of reference. It's hard. You may not accept what that family unit is as far as the values, but you will have to accept the individual and provide the same type of care. Some of the benefits, why would we decide to even hospitalize the child? It's perhaps so they could recover a lot more quickly with the antibiotics that we might give IV. If we implement correctly, it could increase their coping skills with future situations. It can provide a socialization experience of seeing the role of the nurse, in a healthcare delivery system. We have opportunity to teach that family unit. They're kind of a captive audience, and we can try to do some teaching that would perhaps eliminate some situations for the family. So they're a captive audience, and so think of all the things that you might teach them. Of course, when there's readiness for that, of course, is important. Not only does the child have stressors of hospitalization, but the parents will also. The disbelief, the stages of grief and grieving when you're told your child has, leukemia or has a heart condition, the fear and the anxiety, about seeing their child in pain and not understanding the complete diagnosis, or maybe you've got a team of experts and they're each kind of focusing on something different and they may conflict with one another, so there's some frustration. Then there certainly can be depression. And so how do we take care of the family? How do we take care of those caregivers so that they can provide optimal care within the home setting? What are the resources that we could help tap them into become an important part of your nursing care? So I'd like for you just to look at this table that looks at family assessment. And we've talked about sizing of the family, knowing who is the person that primarily makes the decisions, and what's their knowledge level, what's the support system for the family, and then how is this affecting, other children in that home. So do look over this table. I'm not going to read that to you. Preparation, when we know that there's going to be a hospitalization, there are a lot of books on the market that lend themselves to bridging into a hospitalization. So those could be considered. If the hospital has a tour that can be set up for them to see certain things, encouraging the child to ask questions, to draw pictures about what they think it will be like. Sometimes the child does not have the vocabulary, and on top of that, the fear that they say it'll happen, to tell the parent about a fear. So having them draw in regards to what they think will happen can lend itself to some very insightful moments with the child. Touching equipment, doctor kit, nurse kit, that type of thing. So, but we always want to be honest with the child, and again, never give them more than what they can handle. So I'd like for you to kind of think about how would we make life more normal, or to normalize the hospital environment. So with your group, I would like for you to make a list of interventions to minimize stress and to foster normalization in the hospital environment, and post these, and there'll be a thread developed for you to post under for that, and you'll post by your group's name. So also think about per age group, how they might respond to pain or to fear. So that can be helpful to you in planning care. When we think about the hospitalized child having pain, or even in the home environment, we can see a variety of responses. So when we look at the infant, we can assess pain in the infant, even though they cannot verbalize it in words, but what we typically see is a generalized response of rigidity, thrashing, loud crying, maybe even high-pitched, the facial grimacing. Say if they have abdominal pain, they'll often bring their knees up to their abdomen and then kick their legs out. If they're having an ear infection or a pain within the ear, they'll rub the ear, pull the ear. So there are different things that we can assess to determine type of pain and location of pain. Vital signs can also, the elevation of vital signs can indicate that. And this is just showing you, of course, an infant who's experiencing pain and what we might see in their facial expression. Now, the child's understanding of pain by developmental age, at 6 months, they're not going to understand that. But they do begin to have a pain memory around 6 to 12 months. And the 1 to 3-year-old, they often think they did something wrong that caused this to happen. Particularly the preschooler who overlaps in the next age group, they think they did something bad, and that's why they're sick or they're hospitalized. The school age, you can look there to see they don't understand the exact mechanics or cause of pain, but there's a better understanding of that when you look at the 10 and 12-year-old, for example. Now, I know you learned in 101, pain is whatever the experiencing person says it is, existing whenever the person says, and that's by McCaffrey in 1999. So, that's a big area that's examined by joint commissions and accrediting bodies for hospitals is, how is pain assessed, recorded, managed, and followed up. So we still need to do that for, the child, the pediatric patient. And then if you would look at that and just see the changes in respiratory, neurological changes, metabolic, and on down per system, what we might see for a child in pain. There are different even testing forms or assessment forms that can be used. One is called QUEST. You question the child, you use a pain rating scale, and then on down the list it goes. What you're probably most familiar with is the Walker Baker pain scale of 0 to 5, which is a smiley face. Now, the child around 3 can utilize this by looking at just the pictures. They can't give a quantitative increase that 3 is greater than 1. It's hard for that preschooler to do that. But what is very important is that you give an explanation. So under 0 or no hurt, you might say, this is when you're playing and running and laughing and, tell me some things you like to do. What do you like to play? And so you can, associate that to a knowledge piece that they have. So you want to reference these pictures. So there has been some questioning of using these pictures because of the cultural expressions and what that means in different cultures. So you have to be careful with that as well. This is another scale that's called the Alcher scale, in which on your paper it doesn't show up quite as well, but they have a more realistic picture of a child, a photograph, that's showing those changes. So the FACES pain rating scale, the numeric scale, the FLAC scale. So there are several that are used. Even for the high-risk neonates, there are specific scales that have been researched and are evidence-based that could be used. So then when we think about treatment of pain, that's going to consider, based on their age, positioning, swaddling, distraction, relaxation, diversion, and you'll be doing a skill test on diversional activities. So there are a lot of different things that can be used as interventions that are pharmacologic in nature, and so those can be tried as well. Then this table addresses the misconceptions about pain in infants and children. So I'd like for you just to look through that and have a better understanding of pain and what we see in reality. There are different types of topical and local medications that might be used. One is Imola or Nubby Snub, an intradermal local anesthetic. But all of these have a timing factor and how we apply different creams. So this is one study that was done that said or showed that it was very helpful that you would apply the Imola cream 60 minutes before procedure, and it lasts about an hour after removing the occlusive dressing. Now, some references say it'll last up to 2 hours, so it just depends on the manufacturer of that particular topical cream. But note there's an importance of time illustrated here. So opiates, NSAIDs, potentiators, cocktail mixes of medications. So we can see that there are pain medications that can be used, but they're going to be based on the body weight and then also titrating using the smallest amount and then, assessing that and then moving forward. The ceiling effect and the first pass effect, and then patient-controlled analgesia or pumps that might be used on, say, an adolescent. This is a picture of how you might see the Imola application used. It'll say in the literature you put a large dollop over the area and then use an occlusive dressing on top of that. This is just showing the application and the application of the dressing on top. Diversion in play, and of course this links into your skill testing. You want to have a diversion that's age appropriate and based on the child's cognitive level. You might use equipment, you might be doing explanations, the family may be involved. And so what you are doing is providing atraumatic care when you employ a diversion for a situation. Then you want to document the results of that. Some other things to consider in regards to hospitalization would be the effective isolation, being in an intensive care unit, going through an emergency department, if the child's had numerous admissions. And often we'll say, we are our past experiences. So if the family unit had a child to die, we might see, extreme overprotection for this next child. Do they have to travel a long distance? Knowing what that would be like for them. So when we think about the hospitalized child, we want to offer play, toys, and activities for the child. Play is the work of children, and so it's psychologically very important for them. So it can be used in a variety of settings. So you first need to have a definition of what are the different types of plays that are used in literature. So solitary or one-sided type of play, of course, would be, during infancy, they're not really engaging with another child. They might be doing a cause and effect when they, hit a mobile, for example, that's, over their crib. Parallel play, this is what we see primarily during the toddler period, where the two children would play alongside each other, but they're not inclusive. They're not interacting with each other as part of that play activity. Then associative play is more of a group activity that can occur during preschooler, and usually their attention span to do that play activity is about the number of minutes and their number of years of age. So if they're a 4-year-old, they're going to be on task maybe with this for about 4 minutes or so, and something's going to have to change to keep them enticed. And, these are those beginning games like Duck, Duck, Goose, or, Player in the Middle, that type of thing. Then dramatic play is, acting out a role, dressing up in, the fireman stuff, dressing up like Spider-Man, fantasy roles. And note that with preschoolers, they often can't differentiate between fact and fiction when they're playing these roles. And they may also have imaginary playmates. So some of the functions are why we might use play in the hospital setting or even in a clinic setting. It can provide diversion and relax the child and give them a sense of feeling secure and safe and decreasing their stress. So it can also have therapeutic goals. We could be teaching them something through the play, or we might be examining what their perception is when something happens. But it has to be age appropriate, recognizing their cognitive level, and do they have the energy and wellness status to participate. The phrase therapeutic play is often used to describe what you might do to prepare a child for a procedure. You always want to assess their knowledge level. Where is your learner at? With information about that procedure. Avoid words that have double meaning. Be honest. And evidence-based practice shows that if we are teaching or using therapeutic play about a procedure, that we should incorporate sensory aspects. You'll smell this. You'll feel this. When the medicine goes in your arm, you'll feel warm. So responding or helping the child in regards to sensory aspects is research supported. Then we always want to give praise. One of the principles is that the child's doing the best he can do. So find something to praise him and the parent as well to develop that relationship. So what I'd like you to think of is what would be if you were working in a clinic or in a hospital setting and you had a basket at your nurse's station or center, what things would you want to have in there that might be helpful to you when you would be teaching different age groups or providing a diversion? So you'll enter these responses on discussion board as you've done before. So I want you also, a second assignment now, or a third one would be to identify an example of how play can be used with the hospitalized child, and you can select a particular situation that you might be familiar with, asthma or respiratory infection. The example should be age appropriate and safe, as you see there, and then post those responses. Now, this is something that might help you in your studying, but you don't have to post this. Prepare a card on types of play. and identify the purposes of the play and benefit, and maybe even particular toys that would be age appropriate and safe. And this would help you in studying for questions about play in the hospitalized child on exam 1. So to summarize, we want the effects of hospitalization to be understood by the uniqueness, of the child and family. To recognize that there are nursing interventions that can help the family cope and adjust to an illness or hospitalization. To understand the different types of play and how they might be incorporated for teaching or to understand the child's responses. Know how to assess for pain, use age-appropriate assessments, and I'd like for you to look at a video, search for one on YouTube for treatment of children in the hospital and see what you find available out there, and critique that to see if you think it matches up to what I presented to you or in your textbook. So this really concludes a follow-through for you for this particular presentation of PowerPoint, and I wanted to recap some things in your textbook. Of course, I asked you to look at stressors of hospitalized children, and then to look at the loss of control or the effect per age group, and then strategies for working with the sibling of a hospitalized child. There's a section on that in that chapter. Family assessments, how a child might be prepared for hospitalization, and it gives an example of some books that might be used. That would be helpful for you to know. When you're preparing a child for a short stay admission, what can you do to tell the parent to take to the hospital or to have if there is time to secure those items. Then you have an example on page 1034 that looks at how to prepare a child, and it's a clinical reasoning question. Then a very good one on medication administration that will help you with your skill testing is the variations in medication administrations to children, table 40-7. So if you'll look at that, and then how to assist a child through procedures. And I'm basically just pointing out some of the tables that will give you more of a summary and go-to information. Pre-op checklist, nursing care plan is listed there, the different types of play if you need to read more about that, know what a child life specialist does on a unit, and therapeutic play techniques that could be used. And then if we're transitioning to home, there's a section on preparing the child for home. So if you'll look and scan through those tables, and you may even want to Xerox or copy them to go with this study section and for your exam 1. We'll discuss some of this information and apply it in class. So I will have this posted for you to look at.